My name is Ryan Pegg. I'm the board member of the ACHE chapter here locally, which is called CAHL, and I help plan these events, so I really appreciate your support in coming out. Please be sure to sign in if you haven't already done so, and take a flyer. We have several events coming up in the next months and ahead, and we look forward to seeing you at each of these events. With that said, I want to turn the time over to Dr. Jennifer Tong, who's the CMIO of Contra Costa Health Services, who's going to lead this discussion tonight, and she will be introducing our fantastic panelists. With that, Jennifer.
All right, thank you everyone for coming, and thank you for having all of us. My name is Jennifer Tong. As was introduced, I'm the Chief Medical Informatics Officer for Contra Costa County. And I'm only 4 weeks old in that job, but prior to that I was in the same position as CMIO for Santa Clara County and had been there for the past 12 years. And I think as many of you probably already know, and you'll hear tonight, the field of population health is rapidly advancing sometimes faster than our technology and even our staffing can keep up with, but a very exciting field. And the public safety net system in California has long-standing work in the field of population health, even before it had become such a buzzword in healthcare conversations. There are 10 public safety net systems in California. I've been very blessed to be part of 2 of those now. And for decades, we've been addressing some of the most complex social challenges our patients face, with attending to patients' social needs around homelessness, food insecurity, jail recidivism. We've had increasing capitation arrangements even before many other systems have. And more recently, our government funding is very focused on the performance of certain population-based metrics. So it was not until recently that I realized I'm actually doing work in population health, and what an exciting field. So I'm thankful to be here tonight, and I appreciate the panelists being here. I'll go ahead and introduce each of them, and I'll ask each of them just to say a couple words about themselves, and then I'll kind of introduce the format for our session tonight. So from the left, we have Dr. Amy Sitapati, who is the CMIO for Population Health at UCSD. Would you like to say a couple words?
Yeah, thanks so much for having me. It's such a pleasure to be here. I'm an internist. I see patients in primary care 1 day a week, and then the other 4 days my focus is on quality and development of population health tools and strategy. I oversee a team of analysts, and we sort of design and innovate the tools that we need to deliver better health care. And I've been in this role, it depends how you cut it. The most recent title and role, about a year, but actually doing informatics work in this area for about a decade.
And next we have Dr. Ian Tong, who happens to also be my spouse, and is the Chief Medical Officer for Doctor on Demand.
Hi, thanks for having me as well. And it's true, so yes, I'm the Chief Medical Officer of Doctor on Demand. Doctor on Demand is a nationwide telemedicine practice, so we essentially do video visits, and we actually do them on demand. So that means that patients who need access to a physician for mostly urgent care problems are able to access that physician within 3 minutes. We also offer psychology and psychiatry, so all those services are offered nationwide, 49 states. When I say nationwide, in August 1st, it'll be 50 states with the advent of Arkansas, allowing a doctor-patient relationship to be established through a telemedicine visit. My first 8 years of my career, I was an internist at the VA Palo Alto healthcare system. I was the medical director of Veterans Outreach there. That program focused on access to care for homeless veterans, rural veterans, and veterans who are coming back from Iraq and Afghanistan. And so with that program is where I was introduced to telemedicine. The VA was really 10 years ago. It was a national leader in the area, really still is. But I was fortunate enough to get to build different programs there in terms of improving outreach to access to care for our veteran population. So I'll talk from maybe both experiences today.
Great, and then we have Richard Soohoo, who is the Chief Financial Officer for Sutter Medical Center, Sacramento. And Richard, it's unlikely you'll announce this about yourself, so I've been asked to share that Richard was recently awarded the CFO of the Year by the Sacramento Business Journal.
Well, to be honest, I was the only candidate, so. But thank you for that acknowledgement. So I'm the CFO at Sutter Medical Center, Sacramento. I've had a number of finance positions within the Sutter Health System and have been with the Sutter Health System for 29 years now. So it's been home to me for a while professionally. Most recently, I was CFO at Sutter Medical Center, Sacramento, and have been in that role for about 9 years now. And probably many of you who live in this area know that we just closed our old Sutter Memorial Hospital and moved it to a brand new hospital, which now we call our Anderson Lucchetti Women's and Children's Hospital. So my role is in a finance role, obviously, is to make sure that, you know, we're prudent in having effective processes and that we have good quality care, as well as being able to be affordable and create access for the populations that we serve. I'm very much interested in hearing questions and learning from our other panelists about population health as well. I see it as, from the hospital side, we're kind of on the back end, and we fix and heal and return people back into mainstream. But population health is a real different design than what we currently have. So very interesting how population health is really going to kind of take on more of healthcare in our landscape now and in our community. And I really think that it takes the whole community in order for population health to work, and understanding what our roles in each care section of that on how we make population health work. So thanks for having me.
Okay, so our format tonight is that we've selected 3 or 4 broad themes in population health, and we have a few slides that support those. By no means do we want this to be a slideshow presentation. In fact, the slides are going to be behind the panelists, so they certainly won't be relying on those too much. But they're there just to support the topic, to spark some ideas in your minds as you watch and listen. And throughout the next hour, we may pause to take some questions from the audience. We'd like for it to be interactive. Those don't all necessarily have to wait for the end, so if you'd like to make a question or comment, feel free just to give me a visual cue, or I may pause and ask if anyone would like to ask a question of the panelist midway through. So I've been to population health conferences that last days, 3-4 days sometimes, and so it's quite a feat that we're going to try to cover such a broad topic here within the next hour or so. And I've also been in meetings where we talk about population health, and it's such a broad topic that I will say to myself, what are we talking about again? What is population health? So that's actually the first theme of our evening. What is population health? What are we talking about when we say that? And so I'm going to ask Amy to go ahead and make some comments about what do we mean when we say population health?
Yeah, thank you so much. When I first realized that population health was becoming a something, I said, well, what is it exactly? I think I'm going to look it up. And so I went to my Google search and put in, population health, and it was really unclear. I read through journals and articles, and actually before I came tonight, I thought, I wonder if it's changed. There's a lot more hits. Wow. But there's still just as much confusion. And population health has evolved. That's the real story. And I think when we started, we were thinking about public health. We were thinking about things like tuberculosis and cholera, and how do we have our communities targeted so that we could avert these massive catastrophes. And then what happened is we had new therapeutics and things happened, and people started saying, I wonder if we could deliver healthcare a little different. What's a quality of life measure? I guess mortality isn't everything, right? We should come up with some more measures and things. So there were more articles that came out and more publications, and then people had conceptual models and concepts and all of that. And I think if you go to read today, you'll hear about all of these type of things. And you'll hear now about tools. I mean, people have tools for pop health. They have predictive models, predictive analytics, risk acuity care, care management that's coordinated, integrated data, and we could go on and on. We had to learn this whole gobbledygook of new language. So I asked myself, what am I going to say when I'm asked, what is population health? Well, I think it's all the things that we have been, but it's something new. And I think the something new is population health is a therapeutic. We are directing resources against individuals who might have a certain risk, have a certain ailment, and we're going to change the health of the person and the population because of it. And you might say, wow, that seems impossible. We've already been doing it. That's actually how we eliminated smallpox, but we're going to be doing it not by the one and we all meet up and go around and sort of give our injectables. We're going to be using medication, education, therapeutics, the community. We're going to use the resources that you see up here. So absolutely we need new community partnerships. We need our employers to also be mindful that certain employees, guess what? They can't work 14, 15 hours every day. It's not good for their health. And it's actually in the long run going to save them money in terms of the cost they have to spend in healthcare. If the employee goes for a half-hour walk in the middle of the day, maybe that's a better option. In our healthcare system, yeah, we could spend a lot of money in our intensive care units and sort of resuscitating and giving these amazing biologic agents. But shouldn't we also be averting part of that healthcare? And it's bad when a patient shows up, they're harmed. It's not just the cost. They're never the same if they have a real serious health condition. So what can we do to make a difference? And all those things are population health. So what does it come down to? Can it be done? Well, I'll tell you, I thought maybe not. I was working in my practice, and I had a lot of patients, and I told their quality measures, and some good, some bad, some not moved. And I thought, I'm trying to do a really good job here. I said, we're going to approach it differently. We're going to take you're going to use analytics. We're going to bring up the whole population, and then we're going to have a strategy to approach the population. The people that haven't been seen, that's your job, go get it. The people who have social determinants, they need a social worker. They need mental health services. Your job is to do this. And these patients that have the worst metrics, they're the highest risk for death because of these key lab values. Guess what? We're going to do something different. We're going to bring all the team together and we're going to work on that patient. Well, you should have seen the experience there because the doctor said, hey, Janie is never going to change. I said, what do you mean? Well, I know Janie for 10 years and I've been talking to Janie and Janie is never going to take her meds. And I said, well, obviously it's not working. You know your patient, but the patient needs more than you. You're doing a good job, but we need a different approach. So we're going to take the sickest patients and we're going to work through the list. And we were doing this for an HIV positive population. And if you can believe it, when we turned in our quality measures for these big programs that are now value-based care, guess what? On my favorite metric, which is viral load being undetectable, that's probably the best thing to protect you from dying from HIV is a low viral load. We didn't meet the quality measure. We lost the measure, we lost the money. And it really upset me, not because of the money in the measure, it's because it meant that it wasn't having an impact on the population ultimately. I said, how can that be true? We sit around in the meetings and we see 1 million copies go to 500 copies. We see 500,000 copies, down to 700 copies. What's going on here? How come we did such a bad job? We weren't measuring it right. So I said, let's rerun the data and see if we actually moved the population's viral load. Something nobody ever does. Guess what? Down 40%. You know what that means? Someone's not dying. That means someone's not catching HIV. And that's how we have to look at population health, I think, in a new way, in a new paradigm, and use it as a therapeutic.
Okay, so with each section, I'm going to give the other panelists a chance to chime in. So you do not need to feel obligated, because then we might be here all night and never get past the Richard and Ian, would either of you like to means to you?
Well, I really like what Amy walked us through there, and I would just, and so all really well said. I think when I think about it, and I think some of this paraphrasing a little bit what you said is we're going from a sick care system to a well care system. We're not just going to be focused on disease management, but really all the things that impact the patient, whether that's the neighborhood you live in by your zip code, right? We know we can tell a lot about a patient by the zip code that they live in, maybe more so than just the disease processes that are in their family, right? There's a family history, but there's also a socioeconomic and demographic profile as well that can be linked back to where you live. So I think that's one important point is just changing, sort of where along the line of the life cycle we're impacting patients. One. Two is to do that. That means you have to change how people see. You have to change how people see healthcare, right? So they think about going to the doctor when they are when they are sick, and that's what they've been taught to think. But we have to start to become something more for them than just a person who can provide a prescription. We have to embrace the opportunity to educate patients rather than waiting for them to come to us just when they're sick. And that's, I think, a little bit of a sea change, though, for doctors and for our health systems. It requires that we really look at what we're doing and ask, are we meeting the patient where they need to be? And I'll just use one example. At the VA, my program for homeless veterans, I was on a mobile clinic. We designed this program to lower every barrier we could. So there's no cost. All of these veterans have free care. We would go to the shelter where they were living, so they didn't have to go anywhere to see us. We did not require appointments. We would go literally, when they didn't come into the clinic, to the mobile clinic, we got out of the mobile clinic and we went into the facility and we got permission to go in there and provide them care there. And so I learned a very humbling lesson at that point, which was that, actually people don't really want help. They don't actually want to talk to me. I think I'm a nice guy, I think I'm approachable, but it doesn't matter. The patients did not want to engage me where I was sitting and in my role. So we had to figure out other ways to do that. I think that's a big lesson, and just to link that to what I do now, I feel like that's some of what we're doing. We're trying to meet patients where they are and trying to change the experience altogether. So I'll stop there. I think I could probably go on for a while too.
So great comments, great insight. So I asked a question because this is all driven by data. Where does the data come from? Who holds the data? Whose medical record is it? And we talk about taking the care to the patient, to the population. We talk about VA, but that's such a small segment of our population we need to treat, that we need to get to. So I think about that. How do we finance that as well? I know the finance guy comes out on me. How do we finance? Whose responsibility is this? There are handoffs that have to occur in all of this. And I think about that. I'm a board chair for a community clinic that was a specialty clinic where we treated HIV/AIDS patients here in Sacramento. And it was a great clinic, wonderful clinic, and had great outcomes. And the first thing I asked was quality measures. And this clinic was the start of the 4 health systems here in Sacramento who came together and funded it. Because they knew there was a disease that needed to be treated, the virus. But that's because it was an epidemic here that we didn't know about and how to treat it. But now we have so many other diseases, and how do we come together and collaborate on that? It can't just be the health systems who are funding this. So this clinic went from a specialty clinic to now an FQ8C, a federally qualified health clinic. And we have a number of those in town. And I asked the question, and I asked as a board chair, so why are we doing this? What's the purpose behind this? And so many clinics now become FQ8Cs, and I hate to say this, but there's truth to this. They chase the dollar that's included with it. And what I mean by chasing the dollar, in California we don't employ physicians, corporate practice of medicine, but in a clinic, an FQ8C, they can get anywhere from, depending on your service loads, what you're treating, anywhere from probably $250 the low end, up to $450 for a primary care visit. Now, take that reimbursement and go to an IPA, a medical group, they don't touch that. So how do we get patients aligned? Now, this is a population that spans across both government-sponsored and commercial. And I think these clinics need to become primary care clinics that service all of that, regardless of payer. And so when I think about that, how we fund that, and these FQACs now can offer loan forgiveness for incoming primary care physicians, where hospitals and normal IPAs, medical groups cannot do that. So I think the government is catching on to this and saying there's some really good models out there, but we're still so far from that. We have still such a huge gap in our community in treating and creating access. And what we've seen is the population health is just starting really when I think about that population and how many folks we serve. I look at the hospitals and with the ACA and the California Exchange, great idea, wonderful idea, but a lack of education on individuals on how to use their new health care. So our EDs become inundated, which is the most expensive health care there is. Why couldn't we take that ED expense and realign it somewhere else where we really get the bang for it and truly treating the whole patient and creating them, giving them a great quality of life. So those are the things I think about population health. Probably have more questions than I have answers, honestly. And if I had the answers, I wouldn't be sitting here. But I do have tons of questions. I think that everyone partnering together through all levels of continuum of care, we can get to that spot.
So Ian mentioned going to meet the patient where they are, both sort of in their mind and physically. And I'll share with you that one weekday morning around 10 a.m., I called Ian, I think because one of our young kids was probably sick and needed to be picked up from daycare. And he said, I'm in a bar in Half Moon Bay. And I said, what on earth are you doing in a bar at 10 o'clock in the morning in Half Moon Bay? He said, I'm seeing patients. This is where I meet the fishermen. And so I thought that was a good...
I have program for that. She bought it.
Yes, a liberal understanding of the ecosystem of healthcare. So Ian, why don't you kick off our second theme here about the ecosystem of healthcare and how it's changing?
Well, that definitely is one of the more extreme examples. Maybe it's worth talking about the traditional players. Always we think about the doctor and the patient. We have a doctor-patient relationship, which is something that I think is sacred. It's something that I taught in medical school at Stanford. I forgot that I didn't really get my medical resume. I'm an internist. I'm a clinical assistant professor at Stanford, and I taught in the medical school there. And specifically what I taught was doctor-patient relationship, and then mentored students through their entire curriculum until they graduated. And so I think that, but we didn't learn any of this kind of stuff in medical school, right? And we didn't really teach as much about the healthcare system. There's always one or two healthcare economics courses, often taught by someone from the business school, but rarely taught by someone who's a physician who's actually lived it, because they don't get close enough to it usually to be able to have the expertise to talk about it and teach it. But those traditional players, I think, are important to acknowledge. And then also we'll just say payers, health plans and so on, but also employers who are traditionally paying for the care. And many of you probably know the history behind that post-World War II, why employers ended up picking up the bill in many ways for paying for patients' health, or their employees' health care. So I wanted to just make people aware of what I've seen now in trying to address really the access question and really maybe the care coordination questions, because I think those are two really big challenges that the ecosystem faces, and why there are so many different ecosystem players now, right? So I listed for you all the traditional players, or some of the traditional players. I mean, there certainly are more. If you RNs, PAs, and so on. There's a ton of different providers, payers, and then patients, but what the patients need, and I think what population health has grown out of, is that the patients do need more, right? The story that you told about the primary care provider who says, well, I'm doing everything that I can, which is true. I don't think you can ask primary care providers to do much more. But the patients still need more, and some patients, some portion of the population needs a whole lot more, and it's not just that provider, it's it is the social worker, they need a behavioral specialist, they need a lot of different things. And the system does everything it can to make it difficult for them to access that. And so what happens? Well, they don't get the care that they need. And so what we've seen growing in the ecosystem are private companies who are providing services around navigation. So these we call them navigation companies that essentially offer, and you guys may know some of these, like a Quantum or an Accolade. They offer patients a single phone, and employers a single phone number. Basically, it's a phone number and the ability to have access on demand to a person who's knowledgeable about the healthcare system, about that employee's health plan, and then helps to direct that patient and architect a pathway for them for better health through this really complicated, complex system, right? And so it's good that we have that, but maybe shame on us that we need it in the system that we created. There are other ecosystem partners like that target specific disease conditions. So diabetes, for instance, right? This we know is a very costly problem. It's a population I think that many employers want to identify so that they can address, because they realize that average patient might cost them anywhere from $10,000 to $14,000 a year to manage. And if that patient or that employee has 2 ER visits two visits to the ER in a year, then the cost of the care is going to be a losing proposition for that payer or for that employer. And so this is a huge expense for them. And so they have hired companies that will just target that single problem, and what they'll offer is free test strips and maybe a smart mobile device. There's a company called Livongo that does that. And they offer a dashboarding for the patients, and then they offer certified diabetes educators. And so now I think the reason why I think they're really interesting is that they are providing a lot of services for the patient, but they're doing everything up to optimizing therapy, because that's what you need the physician to do. But so again, in a nice way, they're leaving or allowing the physician to focus on using the power of prescription and the critical thinking and knowledge base that they have to adjust the medication. And so that's a little bit more of a technical challenge, but the doctor does have the expertise to do that, and so they're relying on that. But they're kind of saying, well, we're going to offer all the other pieces if we can, and that's mostly because no one really has gotten primary care fully figured out. Maybe I should restate that. We've done a really good job for quite large parts of our population, but there's enough of the population that's being left out or not getting all the answers, and so these different partners have really popped up to be able to provide these services. And then finally, there's maybe another group I'll call out, or are aggregators who bring together a lot of different services. So let's bring together the pharmacy, it's really different parts of the benefits to make them easier to understand, find the best value, right? So better access to the services or resources, finding cheaper prices, and then also right in the traditional value-based healthcare equation, gives you a higher value in the end. So those are just some examples.
Follow up on that. I was recently shopping at Costco, and as I walked out, I said, what a great experience. I got everything I needed, some things I didn't even know that I needed, but because Costco chooses high quality items, I think I've selected something high quality, and while I was there, I got lunch, probably not the healthiest lunch, but I got lunch, and planned a vacation, by the time I got to the car with my little pamphlet. And I said, really, healthcare needs to adopt the Costco model. It should be, you go one place, you get all the different things you need, and some things that you didn't even know that you needed that are high value and crafted and presented to you right while you're there. So, Amy, Richard, anything else that you'd like to add about the ecosystem of healthcare?
When I think about the ecosystem, I know locally many of our hospitals and emergency rooms now have navigators, as you mentioned. And when someone comes into the emergency room, the navigators help them navigate the system. The challenge is, though, that they find these patients, and when you have to help them navigate, is to get them connected to a primary care follow-up, sometimes even a specialist. They're not available in the community. So it's a great concept. It's a novel idea, but it really hits the wall because they're not available in the community. And we all know the story. Go home, pull up the phone book, or Google a primary care and call, and you're not going to get one unless you know someone who can get you into a primary care doc. That's the reality of it. So some of these concepts are really novel. I think they're great, keen concepts, but there still is the pragmatic piece of it, of how we apply it and make it effective. When you think about the population health as well, the data that goes behind it, no one likes to be profiled, but this is truly what we need to do, is profiling. And we need to look at the profiles of the populations. We all know in healthcare that there's 30% of the population that's spending 80% of the healthcare spend. So why aren't we looking at that 30% of that utilization? Population health is going to cover all of this. And I talked about the commercial population as well. We all want population health as well. I would love to see that. But there's also another population within the population health rollout that we need to be cognizant of. And not understanding what we need in the different communities. And when I say different communities, just 20 miles from here, there's a different population need than what we're sitting next to us here. And we need to understand that. And we can send navigators out, we can do a lot of really nifty things, but we just don't have the data on that yet. And you know, we've all had manual medical records before, most of us are on electronic medical record now, but there's limitations with that in harvesting data. And then where's the data warehouse, the big data that everyone talks about, conferences you go to, big data. But yet I've yet to see someone who has all this big data. When I think about IBM Watson, that's out there, the data that they're trying to get to and look at some of this. I think it's a really novel concept, but we have to be willing to say, am I willing to give my data up to participate in this? And does everyone know what their data is? The population, that 70% that is the healthcare spend, they don't even know their records.
Really interesting. Maybe I'll take a different angle and just say, you know, from my perspective, I think we're ready for a major disruption in healthcare. As an internist, it's not uncommon that my first or second patient shows up 30 minutes late. Oh, doc, I'm so sorry, there was so much traffic. And I'm thinking, oh my. Because, you know, every patient thereafter is going to start with at least 30 minutes, and we're going to keep tacking on, right? Unless someone no-shows, which is not usually the case. So I think we need a disruption of healthcare. And I think a lot of what we can deliver in terms of population health means that we don't need all that fancy overhead. You don't have to go park and maybe pay. You don't have to greet the people at the front desk that say hi and then take all the information down, and then someone else takes you to the back and asks you more information that you could actually probably enter on your own. And then, you know, you wait the 30 or 40 minutes to see me, and I walk in the room and you're like, I gotta go. You know, I gotta get back to work. Or whatever is the case. So we have that visit and then you're gone. Did you actually even need to come in? And I think the new technology that's available will enable us to do things in different ways. You know, I have a patient that came in, was having some problems with tachycardia. And the patient said, well, you know, I'm trying to get in to see the cardiologist. You know, they're supposed to ship me this, that, the other. I said, you know what? You can do this yourself. It's less than $100. Get your watch. You'll know every time your heart rate's over 100. And if you want to get if you have an, you know, certain kind of technology, you can even get an EKG. I mean, it really puts brand new technology in people. And you might say, well, yeah, that's fine for all the youngsters. But my practice is mostly actually, you know, probably average age about 70. So, I mean, it doesn't matter what your age is. Even your 90-year-olds can come in with technology and figure out how to use a lot of this. So I think we need a major disruption in healthcare, and I think population health gives us some strategies and tools to really approach healthcare in a brand new way. I can't wait for it to happen.
I love what you said about technology. That's what I wanted to do, right? I wanted to be at a company that where we were going to leverage technology to lower the barriers, to just make it as easy as it could be, but really approach it from a consumer, almost as a consumer. Now, I still call them patients, but plenty of people at the company that I work at do call them consumers. I'm glad they're doing that, so I don't have to, but I think that they should, because they need to think about that person and really for them to be, you know, that the value proposition to them is presented to them at every click. Like, oh, you want this? I can see where that's useful. Next one. And so that we get them to the end of the line where, and by the time they're done, they don't realize it, but they've told me whether or not they already have depression or anxiety, and they told me what their chronic conditions are. They told me whether they smoke or do they drink too much. Like, all those are things that I would have to spend time asking them, but I don't have to do that anymore. Technology should be able to help me have that data in front of me, and so that when I'm seeing that patient on demand, hopefully, so that they don't have to long wait and drive and so on, that I have what I need and I'm able to do what needs to be done then. The other disruption I think we need to embrace is, and everything that I have to do with that patient doesn't have to be in that one visit anymore. But that's how it's been. I mean, it's a lot of stress and anxiety, I think, or demand on the provider and the patient to get everything done in that one episode of care. Very difficult to do, but we do that because it's so hard to get the patient back for the next episode, right? The episodes are hard to come by, and so I think we can release some of the pressure and strain on each episode if we use technology and gather data in between visits and all the white space between the visits. And if you don't use technology that way, I think we're missing out on a lot.
I think one of the things we'll start seeing in the next 5 years is how health systems and even employers support patients in figuring out which technology is most beneficial for them as a patient and how to actually use it. A very interesting model is from Oceaner Healthcare System, which has something called the O-Bar, modeled after the Genius Bar at Apple. And their physicians actually write prescriptions for the patient to go down to the O-Bar, and for the O-Bar staff to help them install an app on their phone or to hook up a blood pressure cuff that they can use at home and transmit blood pressure readings to the hypertension clinic. I think we'll see more and more of this model spread throughout health systems and lead to new staffing needs within health systems and potentially even employers as well. So let's pause there. I'll foreshadow a little bit here and let you know that our next two themes we're going to talk about are around healthcare spending and then how health systems can best support employers in their population health endeavors. But before we move on to those two, why don't we pause to see if there are any questions from the audience about the topics we've just talked about. What is population health and the changing ecosystem of healthcare? We have a roving mic and we'll start with you.
Which systems do you think offer the best model or example of population health today? Are there any?
Well, I mean, I may be biased, and this is being recorded, isn't it? So I'll pick a safe one. I actually spent 8 years at the VA, and I think the VA has the resources and has the scale to introduce certain disruptions or technology into the care. So telemedicine being one. There's a reason why the VA was a leader there. They had a very good rationale. They had a captured population that they knew they had to care for, and they had every incentive to figure out the cheapest and most cost-effective ways to address the needs of that population. And so I think they've built a number of tools, even down to the tools that exist in their electronic medical record that do a lot of the things that I see a lot of companies actually trying to emulate now. So I think that's the short answer.
For me, I could also take just a quick edge to this, maybe, because you were speaking, Jennifer, about the O-Bar. And so I said, well, how did this happen? I mean, I've been following this amazing transformation in a space where I never expected. I have to meet someone who knows about the inside. I said, how did you make it happen? It's the passion. It's the leadership. It's the transformation. And we don't have to look at one health system, I think. We have to look for organizations that have that sparkle. And then it really doesn't matter. They're able to take just the basic things that all of us have in our usual ecosystem and make it beautiful, make it totally transform the care delivery. And then how do we have the partnership and collaboration, really to spread that like wildfire, right? So that we all can adopt it.
Quick question regarding the idea of population health and populations that use a lot of resources. Are any of you familiar with the work of Jeff Brenner and the Camping Coalition and hotspotting and using data to find the high utilizers and then really dramatically addressing the social determinants of health and how to help that population.
So, do you want to take it?
What's the, oh, what?
Yeah, sorry, I'm sorry.
Rephrase the question.
Well, I guess it's a model that's innovating in the population health space.
It sounds very similar to the whole person care initiative that the state is engaged with in the public healthcare systems. Amy, is you participating in whole person care?
No, actually, it takes a lot of leadership in your local community to actually make that happen. That's for sure.
So both of the counties that I've been associated with, Santa Clara County and Contra Costa County, are engaging in this endeavor. And it's very similar to what you just said, using data aggregated from multiple sources, not just our EHR, but things like EMS data, housing systems data, jail data, to identify those patients who are highest risk, highest utilizing, highest cost, and then really creating the partnerships in the community. And the public systems tend to have their own behavioral health system, public health system, jail health. And so really breaking down some traditional silos between those areas and working better together to support that very complex patient population. So it's a new program from the state for the public systems. It's only 1 year old, and it lasts for 5 years. So it'll be very interesting at the end of those 5 years to see if we've been able to really affect the outcomes for that population.
I think for people who do that sort of maybe that's not the right way to say it, but who are most motivated to address the population and find hotspots should be the payers, right? If you're at risk for caring for that patient's entire health, then you should be pretty motivated to figure out who are your most at-risk patients, and so there's a number of people I think who've done it, right? So around around Baltimore is one of the places that I'm aware of that this has taken place, but a similar initiative was launched in the VA right before I left. We were doing this exact same thing, trying to stratify patients, and we used activation measures to figure out of that population who were the people that needed the highest level of intervention, and then sort of a medium intervention. And maybe just one, I don't have a lot of intelligent things to say about the question you're asking, I think, but just to say that one insight that I did gain from that program was that there was a lot more mental health prevalence than I had given credit for.
Right.
And then when I looked back over my entire VA career, I realized like actually that's true of at first I thought, oh, this multi-comorbid patient population has a lot of mental health issues. And then I started thinking about my patient panel. I thought actually it's about the same percentage as my normal patient panel. And I kind of see that replaying itself over and over again. And so that's part of the reason why we went after we developed our urgent care model and Dr. On Demand. We had the psychology and psychiatry, because I think we're going to have to really start to have a whole person care. If we're not doing that, we're missing a huge part of the equation for why patients or employees have absenteeism, presenteeism.
Right.
We're just missing. We're just not treating the entire patient.
It's all interconnected.
It is, for sure.
But those are very distinct populations. You talk about hotspots. Let's talk about managed Medi-Cal. Just here in our community. So you find the hotspots, and you profile and you identify 5,000 people with certain conditions. So who's going to take those lives from a risk perspective? Because they're high utilizers. There's a challenge with that right there. Everyone backs away from it. So the hotspots I totally believe in, but again, the infrastructure has to be there to support that. And we're talking about profiling is what we're talking about here. Pulling the data to profile what we need in our communities and not stereotype people. We need to understand what those segments are that we need to address. But we only have so many payers now. It has consolidated. And the payers take those lives and they have to go on contract with medical groups and hospitals. And once they know that their population is X, Y, or Z, and someone else knows about that, it's a real challenge from a contracting perspective. So until we level that playing field, so it's going to be a difficult haul for us. Although it's definitely necessary to know where those hotspots are.
Any other questions from the audience before we move into our next section? So get the microphone to you.
now? Are there things we can do before people are even sick based on that project?
Well, you know, we've been giving thought to that, I would say, at UC San Diego in the biomedical informatics department. I'll say that there's a lot of work to do. I mean, first of all, we talked about privacy, privacy issues to your data. Then we talked about where is the data, can you even see it? Right now it comes in a PDF and you scan it in, and even your BRCA 1 and 2, risk for breast cancer, guess what? It's in some PDF somewhere. And if you were supposed to change the frequency and type of screening that you're going to do on that patient, I hope that you entered it somewhere you're not going to forget. So I think there's a lot of work to do. I think that people have to get more comfortable with what it means, and then we have to be assured there's not going to be discrimination based on sort of genetic profiling. I'm a victim of prior profiling. I worked in a hospital, caught tuberculosis, and then when my husband lost his job, I had a baby, I had like 2 months off work, guess what? No health care. Nobody was going to take me with prior tuberculosis, even though I caught it from a patient. So I'm very sensitive to what that could mean from that walk of life, but I think genomics is going to be wonderful, because shouldn't we know that drug X is going to be terrible for that patient and great for this patient? Why do 30% of patients on Coumadin have to show up in the emergency department, with some kind of active, terrible thing? Maybe it was a fall and they bruised, or maybe it's a major hemorrhage, we don't know. But it's too much. So we have to figure out how to get the meds and the screening and the treatment all right. And genomics is going to help us get there, but we have a lot of work to do.
Never used the word disruption 4 times in a panel or a presentation, so I'm going to use it one more time. But I actually I think it's an area that is going to be disrupted as well. It's not going to be about the Human Genome Project. There's a number of private companies, and I get pinged by one or reach out from one of those companies that wants to do direct to consumer or through or physician ordered genetic testing. I'm really excited about it, because I think that it does have a place in what we do. For instance, one of the most exciting ways I can see us using it is in selecting the medication. So it's really the ability to take. It's not so population based. It's much more precision or personalized, and being able to use that person's actual data to apply it to a group. But there may be population things that I think become revealed. We don't really know what those are yet, though. We don't know what they're going to be. So I think it's a place to continue to move, for us to move fast and not slow down the innovation, but a place where we have to be very cautious, and I would love for the medical ethicists to keep up, because we tend to develop capabilities prior to our ability to think about, is that a good idea? And how do we, and how do we cover ourselves and do this responsibly and pay attention to the core principles of medical ethics, right? Which is not, first starting with not doing any harm. Those are difficult things. That's what I love about being here, though, and living in the area of the country that we live in, is we are constantly seeing new innovation and always having to ask these tougher questions, and I think it keeps propelling us forward. But the Genome Project is super interesting. It will have a bigger role in the future, but right now, I don't even think I've had enough interaction with it to say exactly how.
I had flipped back to the slide because many summaries of contributors to population health will include genetics, and I realize this one doesn't actually include that, so the ever-changing definition of population health. But yes, I think it's a growing as a recognized contributor. So let's move on and talk about healthcare spending. And Richard, as the CFO on the panel, I'm going to ask you to talk about some of the healthcare spending data here that we are both projecting on this slide as well as the next one.
Yeah, so my question to the audience here is, when we think about healthcare spend, we typically think about the hospital, the physicians. We don't think about EME spend. We don't think about dental. We don't think about pharmacy. All of that's inclusive, and so we talk about health and care spend, and I pulled this slide here, and I thought it was interesting. mean, so many times you hear the United States reference to other countries about we spend so much more and yet our outcomes aren't as great, other countries do so much better. And really when I think about healthcare spend, where does social services fit into this? Is social services a part of healthcare spend or not? And it's a question that we ask ourselves, and when you really think about that, I do think that when you look at the healthcare spend, you have to look at these other countries and then look at what they spend on social services. And it's a complete opposite. If you actually add them together, we're about the same. We do not put enough, and if you go back to the previous slide, population, the policies and programs that are at the foundation of that really would drive so much of population health, I believe. So looking at the spend, I quoted that 30% of the population is doing 70% of the healthcare spend, understanding that. So where are we spending the money? We have to understand that. And it's very easy to look at hospitals and the medical groups looking at that spend because it is big dollars. Those are high ticket items. So that's the first thing we look at. How do we move a patient out now when we cannot get crutches, a walker for a patient through a DME, when CMS has shifted how they administer DME, durable medical equipment in facilities? These are challenges, and these are governmental changes that were made thinking we can ratchet down some costs, but not understanding what the outcome of it was and what the impact was going to be. A 1-day, 2-day length of stay increase in a hospital. That's not great for a patient. All you're asking for is someone to get an infection in the hospital. Hospital is just filled with germs. That's not where you want them to be healing. You actually want them to get them home. So where does home health play into this as well? The home health agencies that can do so much of this work. Getting people back out in the community, getting them into clinics, and you talk about the episodic care, and that's so true. I see it in our clinics, that you go out and you treat someone and then you're not gonna see them again. How do we entice them to get back into that care? I think that we have a spend, but I think there's also, how do we incentivize individuals? Every family, socioeconomics put aside, every family has mobile phones at home. Why wouldn't we give them an Apple Watch or something, as you said, and they could measure their heart rate? There are things that we can do. So I actually think so much focus is on the spend of it, and I actually think we need to invest more in it. Because we're not going to get the outcomes we want unless we invest in it. And the investment I'm talking about is not just necessarily the dollar aspect, it's programmatic that we need to invest in. We have great organizations out there trying to do the heavy lifting of society, but they just don't have the resources to do it. There's not a focus on it. So healthcare spend is definitely huge. I do think it's a challenge for us, but when we really define the healthcare spend, you don't see a lot of information on what healthcare spend is actually by the different segments of it. And when you look at pharmaceuticals, why can't we get more generic drugs? We don't answer that question. And honestly, I'm guilty of it myself. I invest in pharmaceuticals. And I'm happy to get my 401k return. I want to retire early. But let's be honest with ourselves. Let's be honest with ourselves. It's conflicting to some extent. If I'm chasing a return versus what is in the community and the society, what are we after here? And we really need to ask ourselves, and I really do sincerely mean this, each and every one of us who are in healthcare need to ask, why are we in it? How do we make a difference each day? And not just for the one patient, but at the continuum of care, the community. We really need to look at that. How do we educate folks? And I think that going forward, we've been so centered on those homeless, the VA clinics, the population that is underserved. From a population health perspective in the spend, the insured population is primed for it. Most insured population is educated. they're employed. They want well-being in their life and in their family at home. Most of us would say, I will volunteer to put my data forward. I'm okay with that. Because if my family's data is there and I know this, it's a healthier environment. I want to know this information. I want my neighbor, Ian, and his family to have that same data. I want to know what I'm living next door to, potentially, in communities. When we were children, when we go to school, what disease states are we sitting next to? We don't even know. And we do know those in the populations that we all live in. That's the investment that we need to make in this. So I understand the healthcare spend, but I think we also have to invest appropriately in this.
I might ask a question now on the slide. I think it's the healthcare spend slide. So the premise there is that in some of these European nations that that show what we call better outcomes or same life expectancy but lower spend. Are you saying that they spend? They're not counting some of the social services dollars, is what you're saying?
Yeah, on the slide here, they're not showing the social service spend. But think about it, the social service spend is the social worker who helps the family in their home deal with something. That's way cheaper than treating the chronic diabetes in the hospital in the ED because they have it managed. That's what I'm referring to.
Yeah.
So yes, they're investing in social services. They have better outcomes as well because of that. They're treating it up front. They're getting out in their communities.
And we used to talk about the healthcare, the average American and the way they would approach healthcare is that it's like a menu and you can select all the things on the menu and there's really no prices on the menu, right? So they don't know and they don't and they're not also in our system they're not paying for part of it either. And so it's a disconnect between the consumer, the healthcare consumer, and the actual services, and so and who's going to be paying for them. So I think it's a really good point. When I was giving, when I was at the VA and I had care that was being given away for free, and I got at that humbling moment where I was like, well, where are the patients? I realized that it's free may not always be the best thing to, may not always be the best approach because you sort of need to have to have value to the recipient.
I think about where our next generation is, and we spend money on the emergency room, physician offices, the hospitals, less than social services. Let's divert some of that funding, that spending. Why are we in the schools? The elementary schools, the immunizations, helping them educate parent-teacher conferences about good health, about the right choices about what we eat, the exercise. That's the next generation that we're dealing with. Our population is aging, and I understand that. By the time population health really has a foothold, that's the generation we need to be working on and helping move them forward. That's our future. We need to start with them. That's what's going to change the healthcare spend, that investment.
To illustrate this, I was in a meeting just this past week, 2 of them in fact, where we were talking about what metrics is our county healthcare system going to use to measure our success, our performance in population health. And one of the measures that we are thinking about is our high school graduation rate. Initially, many of us said, how do we affect that as a healthcare system? That seems way out of our reach. And then we decided that we need to affect that. Historically, we probably haven't had an influence there, but that is one of the things that we need to be working towards. So definitely some out-of-the-box thinking going on in population health. Now, moving on to our last topic. So the title of tonight's presentation was about supporting employers and how health systems can support employers in their pursuits for population health. So if you came simply because of that title, this is now your moment. I'm sorry it took us an hour to get there, but this is now what the remainder of our panelists talk will be about, and then we'll again allow some time for questions and discussion. So I think as physicians, we don't necessarily think of ourselves quickly as being employers. So Amy and Ian and I think, quickly defaulted to Richard to be the main speaker on this one. So Richard, what can you tell us about Sutter as a large organization that employs many thousands of people, and as an employer, how you are focused on population health?
Yeah, so as an employee of Sutter Health, there's kind of a two-pronged approach here. So I'll speak first from the employee standpoint. So obviously I have my insurance through Sutter Health, and we have started some innovative things, and this is really core to population health. So when I enroll my health benefit plan, I have an option to enroll and say that I will do certain things, and if I do certain things, and it's confidential, it's with a third party, it's not like my boss knows about this or anything, it's really between me and the health plan. And they will say, if your cost of benefits is X amount, if you do these things and you work with a wellness coach, we will discount your insurance costs. That's the incentives, and I thought it was very innovative. And it's almost like, well, that's kind of Big Brother looking over me, you know, how many times do I eat the hamburger and french fries? I have to report that, and I don't know, well, worried. But it really wasn't to that level. And the wellness coach, so I signed on for it. I thought, why wouldn't I do this? And of course, as a finance guy, if I can save 25 bucks, I'm all for that. So I loved that then, and so I signed up for it, and 2 weeks later, a wellness coach calls me and says, Richard, you signed up for this program. And so things like at my age is, when's your colonoscopy, right? A reminder comes to me. It's time for your colonoscopy. So my physician office, integrated with that, reminds me about that. And so on my chart, my health online, we call it, it's reminding me about these things. So it's not slipping. Not the first thing that I'm waking up in the morning thinking, that's what I want to go do. But I know it's for my health. And if I do these things, they're incentivizing me to make sure that I'm in the wellness program taking care of my health. Now, what does Sutter Health get from that? A healthy employee. I'm going to have less time off from the job. I'm going to be a more productive employee, a healthier employee. And guess what? When you have, not that we're all one building, but when you have 55,000 employees, that can be quite the price tag when folks are not showing up for work. So those are things that, from an employer standpoint, I know my employer personally is doing. So now on the Sutter Health Insurance Plan side is going out and trying to work with employers. What type of services do you want? What is your employer and your employee-based profile? What is that age group? How many of your employees are childbearing ages? What's the prenatal care plans and all these things? So trying to create customized plans that go out to market, knowing what companies you're going to market the insurance product for, and partnering with them and understanding what they need. Is it a construction firm? Is it a law firm? What is it? And trying to create plans jointly so you can go out and market, and then creating the incentives so that there's some discounts available to them. And the employer also gets a discounted fee, but also it's going to have healthy employees. And I'll tell you that when you have folks out in the childbearing ages, that leave of absence is a pretty long period. And we all know, like in healthcare for our company, majority of our nurses are female. So it can wipe out a whole nursing unit for us when the childbearing ages are there present for us. So we need to know that. You need to know your population. And so this is where I think population health is so good for us, understanding that. So how often do I exercise? My wellness coach sets up a plan for me. I said I like to run 3 to 4 days a week, and I log that. And it's not I have to turn it in to anyone, but the wellness coach calls me and asks, so did you get your 3 to 4 times a week? And I did 2. Okay, so what's your plan? What are you going to do next week differently? Well, I had a lot of late night meetings or something, and so I couldn't get to it. And it's just a dialogue. And when you think about it, it's a form of social services, someone to help coach me. And all of those numbers are beyond coaching. I mean, so I thought it was a great plan. So those are some of the innovative things that I see that our organization is doing and is out there trying to do. But we're not the only ones doing that. Others are doing similar things as well.
Ian, would you like to comment on how employers are engaging with telemedicine companies to support the health of their employees?
Yeah, I mean, I think one thing that I like everything that Richard said, and I would just say that the ability to engage the population is probably the number one thing. Most of the programs that most employers are offering their employees have about a 3% to 7% utilization rate or penetration rate, right? So they're really offering and spending money on the services and trying to offer one program after another. And depending on how those programs are structured, they're just not getting the engagement really that they need to see or want to see to get the return. So obviously technology is one way to do that. Lowering all the barriers to care. So the way that the telemedicine practice does that, and we try to educate the employers about the various things that we think we can do, and barriers that we're removing. So having to make an appointment, even though that sounds like, well, that's all, we always make appointments, right? That's what you do, you gotta make an appointment. We don't have appointments. I mean, we can get those, we use those for our mental health practice, but you don't require any appointment to see a doctor, a medical doctor in our practice. If you want to see a family practitioner, an internist, emergency medicine doctor, or a pediatrician, you can actually just go on the service, and you'll get one of those types of providers, as I said, within 3 minutes. So no appointment needed. So that means you don't have to organize your day around it. You can use it at home or from your car, as long as you're not driving. Or you can be at the pharmacy because you already have self-diagnosed and you think you're going to need something there that we can actually provide through a prescription, and you may be there to do that. We also can eliminate the cost and expense of time and travel, and we all know that it takes about 3.5 hours, or I don't know the last time everybody in this room has had a doctor's appointment, but it can take up to 3 hours of your day to get that done, and so we are very efficient in being able to offer the care. And then the last thing we've done is we've been able to reduce the costs. So compared to a typical in-office visit, our price would normally be $75 for a direct-to-consumer, but if you have a health plan or your employer has had us in network, then it may only cost $5 a copay for the patient to be able to access the care. And so we're able to really reduce the cost, but also still provide the access. And so those are just some of the things that we've been able to do. It's also the other thing we offer, I think, is what Amy was talking about, which is really fun, is we can integrate with other technologies. I think that's the part that's really exciting. We're not fully integrated yet, but that's going to come. And so I think the next wave of innovation will really be partnering of the different technology companies that offer one solution or another. And I like where we're positioned as the provider, because most of the companies are more technology companies or the navigator companies or the aggregators. And so it would be great if we can plug in with them, because we have the provider group, but just some interesting integrations that we've already done, or something with an otoscope device that you attach to your iPhone. And it was only for the iPhone, so that was a limitation, and that was unfortunate, because we have, we can service iOS, Android, and a web interface. But if you can, if you can put that device on your phone, it was a really nice pilot that we did, and we could evaluate for a middle ear infection. We've also done this with stethoscopes and thermometers. So it's getting there, and it's really exciting to be able to see how to do it. And I think there's a little bit of a wow factor when that happens, when someone's like, hey, I have kind of a little hospital in my house. And I geek out on that a little bit, but certainly there's some patients and employees who find it very interesting as well.
So we have about 15 minutes left in the panel, and so let's use that time to just open the floor for other questions.
Trying to get his steps in. The long way. Yeah, I like it. That was a behavior change right there. He took the long way. Get his steps in.
I kind of have maybe two separate questions. My first one has to do with your thoughts on the direction of ACOs and the impact that they have on kind of overall population health. I know that their intent maybe been criticized on whether they work or not, as far as they're supposed to be using population health tools in order to lower costs and improve outcomes. But I know some people say that doesn't really work out that way. Just want to get your thoughts on that. And then secondly, Ian, maybe specifically for you, it sounds like, I mean, what your company does is pretty neat and innovative, but I was just wondering how that kind of affects the overall population health as well. I'm wondering, like, do people use that just kind of as a, I'm sick, I want to see a doctor quickly, but maybe that would maybe even influence patients not to get follow-up care and a continuum of care or coordinated care type of thing, just kind of the impact that maybe you feel that has on that overall thing. So just kind of two questions that kind of came to my mind during this discussion.
Great questions. I'll start with the first. I think Amy, you probably can comment on the ACO question.
Sure. We're much newer to this journey than many, but I think it allows me with fresh eyes to better understand what the journey is about. So with our ACO, you know, we were wondering how we're going to reduce costs. We're an academic medical center. We have these really high PMPMs, which means just astronomical cost. And it's just, oh my gosh, we have to get everything up. We have 45 registries that categorize all of our patients. And oh, now we need like a new role and responsibility. Oh yeah, we got to recruit the very best who's going to lead the RN case manager, the social worker. Hey, we need a pharmacist too, and all this kind of stuff comes in. Look at the data. Oh, nothing. Oh shoot, we need a new risk acuity score. We got to find the hardest patients, the sickest patients. And I thought, uh-oh, what's going to happen now? Are they going to try to push those patients out? Are they going to call up the patient and be mean to the patient, you know, the sickest? What's going to happen? The most beautiful thing I could have ever experienced happened. They pull up the list, and then they say, wow, we're spending a lot of money. Let's take a deep dive in that. Wow, there's a catastrophic. Yeah, that one got choppered in, and they're in the hospital. And oh yeah, we know that's our neighbor. Could be, because we know people that we care for. They're our community. Next one. Oh, that was really bad. Yeah, that patient, they had, you know, this happened with C-section, etc. This happens, but there was nothing we could do. And now you come to the next one. You know, this one, we should have done something different. Look at this patient's track record. You know, we didn't do a good job following up and making sure that A1C came down, XYZ. And you know, they started tracking and tackling the patients they could do something about and just put the right care right where it belonged. And then you looked at all the curves. Length of stay, readmission, all the curves, down, down, down. Oh my goodness, I didn't think that could happen. And we didn't kick anybody out. We didn't give the wrong care. We gave the right care to the right patient. And it is beautiful to see the ACO journey unfold. That is my story.
Should we go to me take the second question now?
Good. You can go ahead. I ask him this all the time, actually, at home. What's that mean for the patient if they're not going through their
Well, so the first part of it was, yeah, we've had a lot of success in the urgent care space. Those are very episodic, and it's convenient, right? A lot of people call it convenient. I like to consider it as access to care. But we need partners, and that's why I think, this has just been a natural evolution. If I could have had it all at the beginning, it would have been great, but we may not have been ready for it 4 years ago. But now we have, we've built in certain pieces like the patient profile, and we've made that more robust, and we put in the ability to order laboratories, and so that's working well. And so, and ICD-10 and quality metrics, and we have an antibiotic stewardship program, and I learned that we can actually track antibiotic stewardship and prescribing. I can do that nationwide, right? Like I have a patient that's in my network now. No matter where they go, our doctors know whether they got an antibiotic 2 weeks ago, and where it was filled, and we can do that for pain medications and a whole lot of things. So it's really interesting, actually, that we could have been seen as a disruption, but technology is actually allowing us to provide, I think, more continuity, and because healthcare traditionally has been pretty local. It's down the street to the pharmacy, to the lab, and to the doctor's office, and it's all done in that zip code. I'll just make that argument. But the vantage point that I have now is with the technologies. I'm able to kind of see what's happening with that patient, and it turns out they actually leave that zip code once in a while, and no one in the health system in that zip code knows what's happening in the next zip code over. Just because they had to go to the store, because there's not a market in their area, and they went to the market, and that's where they had the heart attack, and so they were in a whole different health system than the one they would have been in, and those two systems that are 5 minutes apart would never talk to each other anyway. So that's the status quo. So I see that, my hope is that we can begin to pull some of that together and provide a better continuity, and we have. We've been able to do that in some cases, but we'll need additional partners. So now we're at the stage where we're in network for United Healthcare, Humana, a lot of the Blues, Wellmark, Highmark, Harvard Pilgrim. These are all health plans that put our physicians in network. So we can partner with them, it makes it a lot easier to actually plug the gaps and then communicate that and hand that over to a primary care provider. So I think success for me would be plugging in and having a patient one day say, oh, I know what this problem is, and I should do this with Doctor on Demand, but this problem I'll actually know I need to go, this one I need to go in for. I think if we do that successfully, then I think the system overall is going to save a lot of money, will reduce a lot of waste, and I think that the patients will actually just have a way better experience, and then we'll change sort of how we see healthcare and the way that we use it rather than sick. Give me some more products so I can use it, because this is kind of making it easier and more approachable. I think that's what we'll hear patients say, I hope. And I think that the last thing, maybe just a really more like kind of tactical answer to that is, so we put the health record in the cloud so that you can access it from your mobile device. So actually, no matter where you are, as long as you have a smartphone, and I know no one here carried theirs in here, as long as you have that with you, you're basically carrying around your health record. So we can provide your provider with a visit summary, or we can give it to you. Right now, we give it to you, but if you put in we're doing this in a few states now. If you put in your doctor's email address and consent for us to share it, we can actually do that. So it's a great question. We're right at that point now, answering that question more convincingly.
We have another question from the audience. Mine is coming too.
I liked your presentation on healthcare spending, and I had a couple of thoughts that I'd like your thoughts about. One is, it seems the more we have the fee-for-service model, that acts as a brake on a lot of these innovations. And it also seems, as we move more towards the payment for outcome model, that the population health process can become more effective and more important. Your thoughts?
No, I would agree with you, very much so. The pay for outcomes, but again, the pay for outcomes, is it segmented, or is it for the whole episode? Is it for that patient? Because remember, our delivery system is very fragmented. And when you think about bundled payments right now in the health systems, they're difficult, because if you have 3 providers going to share in that bundled payment, and the outcome is not good, whose fault is it? Not mine. They're going to point at each other as well. So we have to design that flow of how we identify that. That pay for outcomes is wonderful. Look at readmissions now in hospitals. Hospitals get penalized for that. You discharge a patient and they go home and no one sees them. Is that really the hospital's fault? And that readmission goes on the physician's track record? I mean, so we have to devise a way to really manage that. So if we segment this, it's a little difficult. But I do believe in the pay for outcomes, but it has to be pay for outcomes that is appropriate, that can truly be measured and managed.
Thanks.
I was just going to think that Jennifer and I have a nice experience with the CMS waiver program that the state of California is now in its second 5-year sprint on. And if you don't think money can change healthcare, look again, because when you have a $20 million project that is just waffling on a few quality measures, of course, we will take the workforce and redirect it. Tell us where you want it to go, to some degree, right, CMS. Because when you tell us these 50 things matter, guess what? We're gonna take the whole health system and we're gonna try to deliver on that. Which really is a good thing, because that means we're gonna reduce the number of people who smoke, we're gonna increase the number of people with heart disease that are on antiplatelets and so on, reduce high blood pressure. It holds us accountable to that. But be careful what you tell us to do, because we will really try to get that money, especially those of us. I work in a designated public hospital, even though I'm part of the UCs, right? We have that hospital. And we depend upon that money to make sure that when we have uncompensated care, we can keep our doors open, right? So I think it's really important that we devise the right measures, right? That's gonna make a big difference. If you ask us to reach for those right measures, we're gonna do it. What do you think?
Very much so. For my system, it's $65 million per year. That's critical funding for us. It's not icing on the cake, it is the cake itself. And so, you know, the amount of priority and emphasis and effort put on these state-determined quality metrics is significant. We have time for one more question, maybe, if there's one more question from the audience.
Exhausted.
Since I don't see one, I conclude, and thank you very much for your attention. Thank you to the panelists.